sorry we're starting late. I'm Juan Dumois. I do pediatric infectious diseases. Dr. Vincent Valente is pediatric emergency medicine here in Orlando. And we're just going to have some discussion about the early detection protocol that I presented this morning. And we'll do a couple of things in this session over the next half hour. One, I think, is we can discuss some issues that might occur, some challenges that might occur with trying to implement the guidelines when they're introduced to a hospital and they decide to try to use them. And then the second is how to disseminate the guideline to other hospitals that haven't started using it, just to increase the awareness among physicians about thinking about asking about freshwater exposure. And sitting here in the audience is Dr. Tim Gumpf, who's a pediatric hospitalist in Lakeland. And I actually want to begin with a question to you, because I know that last year you were going to try to get it started at your hospital too, at Lakeland Regional Medical Center. And so I was wondering if you could give us a little update on where y'all are with that.
Yeah, what happened pretty rapidly is they just designed the CSF orders, or inserted into the CSF order for cell count a mandatory question that has to be answered: was there freshwater exposure, yes or no? And so you can't put that order in unless you answer the question. So I think it served an education purpose as well, because if you hadn't heard of it, and now it's forcing you to answer that question before you order CSF.
Does it say, does the question say freshwater exposure for risk of Naegleria, something about
No,
that?
it's really brief.
Just,
is there a history of freshwater exposure?
Brief is better, yeah. Oh, okay. So it's not as long as the question in that particular box that I showed in the protocol, or in the outline. Okay. How do you think that's worked?
I think it has really increased awareness in emergency room physicians. Sometimes they'll verbally include that now when they're admitting a patient with meningitis, which they never did before. They say no freshwater exposure, so I think they're all thinking about it.
That's the main challenge, so that's excellent. Do you recall any difficulties in getting it started, or were you fortunate that it got started really quick?
I think it happened relatively quickly. We have physician, Dr. Daniel Haight at our hospital, who's an infectious disease physician, and used to be director of the Polk County Health Department, but now he works at my hospital as some type of medical administrator. So I think he helped get that done.
Okay, greased it.
What computer system are you on?
Cerner.
And Cerner too. So that's basically what happened. I think when we took it out here, it got to you. And I think it's a one-in-one system, so that's good. That's good. That means it's in all ours. If it's in yours.
No, because Cerner is really facility. That kind of stuff is really system-based. It's not.
You're not a Florida hospital. Correct. If it's Florida hospital,
standalone.
You're standalone. Got it.
Like
right.
Baycare is in our area too, and there I don't know how many hospitals now.
Right.
10, 12
Sure.
hospitals. So if they made a change in their system, which I have to check on that, it would be hospital-wide.
Yeah. The way it works at Florida Hospital Orlando, we're kind of our own entity out of the 38 hospitals for Florida Hospital for Adventist Health. So when they purchased Cerner alone, or the whole Adventist Health, Orlando got a little extra ability to control their own IT system. So I think we're still in kind of a bubble here. Florida Hospital, our hospital system is like the 10 hospitals in this area, but the other 30 hospitals in the Adventist Health, I don't know how to implement
Right.
that. Yeah. Which is because if you affect their thought is if you affect one hospital, if you change something in your hospital, it affects everybody. But that's a good thing in this case.
Yeah.
You're able to get that on.
So it sounds like we have experience from two different hospitals that implementation isn't that hard, that it's feasible, and it can work. In Dr. Kirby's presentation summarizing the protocol, I heard something that might be useful to add to the current algorithm, which was the extra information about the transport teams that were going to bring in patients to the main facility, that the transport teams would carry certain medications, or one specific rare amoeba medication that most hospitals won't carry. And I think that would be nice to add to the last column of the algorithm, something about the transport team. And I noticed that the modified algorithm for Florida Hospital includes transport team that we didn't have before. So we should add that. And I heard a suggestion too that we could consider adding somewhere into the plan that we would inform the local health department that this case is being evaluated. It would not forego, though, the direct contact with the CDC. I actually contacted our local health department last week to ask them what they thought should be done if we had a suspected case, and they said, well, we'd like to be involved, contact us, and we can facilitate transferring the specimen of spinal fluid through the state lab to the CDC. So I spoke with Dr. Cope about that, and she said, no, that's probably not a good idea. You don't want to have to go through the state lab, just go straight to the CDC. So we could sort of just keep the health department in the loop about what's going on. And that can vary county by county, but that we shouldn't do anything that might slow down the transfer of the CSF straight to Atlanta. Because currently our state lab does not do the Naegleria PCR testing, and until they do, then we wanted to send them straight to Atlanta. Do you have any other comments about that? No, about health department connection?
Comment, honestly, and this kind of goes back to the presentations this morning around the potential underdiagnosis of amoeba.
Yeah.
And how long the hospitals are keeping the CSF specimens. I know Steve and I have had lengthy conversations around, if the CSF specimens were required to be kept for longer periods of time. Not that it would help a particular patient at that point if it were missed, but you could at least get a better idea of how prevalent this infection truly is. So, how long do hospitals hold the CSF specimens?
Not very long, I think 3 days or so. Yeah. Usually not very long. I'm usually on the phone with the lab when I know I might want them to hold it for more than just a few days.
And I would imagine, I think from just my brief experience with the cases, that if it weren't picked up on the first CSF, you would simply do another tap, or would you try to revisit the first specimen?
If the first spinal fluid specimen was able to be tested, then we may or may not do a second tap, depending upon what's happening with the patient. If the first spinal fluid specimen didn't have enough volume to run the PCR, then we would not hesitate to ask for a second spinal tap if they can get it. Sometimes the first spinal tap resulted in the formation of a hematoma that includes the ability to do another spinal tap right away until 3 more days after the hematoma subsides in the spinal fluid.
There was one particular case in years ago where the patient was seen in one hospital, it wasn't picked up on the spinal fluid, was transported to a higher acuity hospital because he was declining. And when they did a subsequent tap, they saw the amoeba. And so it was just...
You see that with bacterial infections too, that sometimes with time, it's easier to detect the infection because the first one was a little too early. Yeah. So I think we can make some minor modifications to the current protocol, but the next question is how to disseminate it. A long-term goal would be to every hospital in the nation, but more immediately, I think we try to focus on the hospitals in Florida. And we could decide here what sort of strategy we may want to consider in getting it out to as many hospitals in Florida. Here are some ideas that were discussed last year. One would be to focus on children's hospitals, since most patients with PAM are children. And hopefully they would eventually end up to a children's hospital. That could be maybe a first step to look at, but not the only one. I think that, well, your hospital is an excellent example. It's not a children's hospital, but you're going to see children who may have been exposed.
And our implementation is for all patients, not just children.
Yeah.
It doesn't differentiate, and plus, we have, as of a few months ago, we have the busiest emergency room in the country.
Oh.
Lakeland, believe it or not.
Okay, good. Another idea that was briefly discussed last year is whether pharmacists, so any kind of network of Florida pharmacists could be used to spread the word not only about maybe implementing a protocol in their local emergency centers, but stocking the miltefosine drug from Profounda in their own pharmacy, since it won't cost them anything to stock the drug. Any pharmacists in the room? No? Okay. All right. Well, we have an infectious disease pharmacist at our hospital, and I can ask her about what networks might exist for the state to rapidly disseminate a question about interest in doing those things and help in spreading them. I spoke with Susan Jackson, I believe. Susan Jackson is involved with network things here at Florida Hospital for Children in Orlando, and talked about how the protocol got implemented for the Florida hospitals. And she was involved in the initial meetings where they had multiple stakeholders sitting around the table deciding, okay, well, how are we going to get this started? They had people from lab, from pharmacy. They had people from the emergency center, but not the doctors, because the clinical part of the plan was already established. They just had maybe an emergency center director, nursing director. They helped coordinate how these things were done. And they had someone from IT, information technology, to come up with the alert that would come from the spinal fluid cell count order. She said they only encountered minor things that they would have to address, but once everyone was on board, it happened pretty readily and quickly. After they implemented, they would sometimes find a few problems that they could tweak and improve on the plan even better, and so they are now using the plan that you're using now, and that it seems to work very well. It had several alerts of possible cases. Unfortunately, none of them have really had PAM. She said that she would give me a list of all the children's hospitals in the state of Florida, because I don't even know how many there are. I know there are 3 dedicated freestanding children's hospitals, but there are a lot of children's hospitals within the general hospital. And that might be an easy first target to try to get these protocols established. The presentation toward the end of the morning that Dr. Sharon mentioned, he had done some presentations in the last year to emergency physicians in the Florida Medical Association, caught my interest because it seems like the Florida Medical Association might be an opportunity to find some way to disseminate it to all Florida hospitals. There's a separate organization that he didn't mention, because I guess Florida Medical Association is doctors, but there is a Florida Hospital Association as well. And I think what I could do is ask some of our administrators who are involved in the interactions with the Florida Hospital Association about getting things like this implemented. I just wonder, y'all think it might be easier to do it through the administrative route versus the physician route? I kind of got the impression that what the Florida Medical Association did with that statement they made, that they will support educational activities for the detection and treatment of rare diseases. And it sounded like what they're doing is maybe giving presentations at some of their meetings, but I didn't hear anything about practical implementation, just supporting any efforts. So we could try both, Florida Medical Association and Florida Hospital Association.
I think it's important, I think I agree with you, I think both are important, because the administrators need to be on the same page with the doctors, in order to get the collaboration between them in each hospital. So the doctors, they can have it implemented, but if the doctors don't know about it, they won't implement it.
Yeah, yeah.
So I think it's kind of a dual role. If we could get both of those together.
That's a good point. I think they already, those two organizations already do work together sometimes
I think
for
so.
legislative lobbying.
So yeah, we have this process in place. We want to try to bring a few hospitals together and have the administrators, because they need administrators to implement this into the system.
Yeah.
Because doctors go, I'll use it, but I don't know how to get it into our system.
Yeah.
So I think it's a kind of, and plus it all depends what kind of computer system you're using.
Yeah,
Who's going to build that for them.
right.
So it has to be cost and things like that. So there's definitely have administrators on board.
Yeah, some of the smaller community hospitals may not have as many resources.
And it might be an Epic program or a Cerner program that has it already in the system and just needs to turn it on that site if they want it. You know, or this is what we use for Cerner, can you implement this in Epic or whatever. It all depends on the Cerners too. So obviously, I think we even talked about trying to maybe talking to Cerner and saying, hey, we have this process, how do we implement it into your normal flow of business? I'm not sure.
I had asked our IT doctor about that.
Yeah, might be a lot harder.
Yeah, those are major things that get implemented on all Cerner systems are done in major updates that are only done every few years. And they prioritize what they'll put into new updates. And I don't know if it would fit the priority, but it wouldn't hurt to ask.
Right.
Do you know if there are any, are you aware of any networks of Florida emergency physicians or any even email listservs?
Well, FSEP has, whoever's a member of FSEP.
Okay.
Florida College of Physicians. And so what was great was this foundation has agreed to continue their project that they started, they call it the Pleasant Project. And it was Dr. Sheridan's webinar that he did along now, Smelski did a video, an introduction video about Jordan's case. And so now they have that kind of combined into a package. It's available for all the members. And I think we have to do a better job, obviously, advertising this with FSEP. Do FSEP thinking of it as out to everybody by whoever is on their listserv for members. So,
Yeah. Even if they have a newsletter,
right.
that we could publish the algorithm.
Exactly.
Yeah. Yes.
We talked about thinking innovatively, and if you're going to try to get it into more hospital systems, they're all on different systems, and you mentioned Cerner and Epic, two bigger ones. But I would recommend approach for detection from the IT end, and writing an algorithm or a protocol on how you implemented it into your system. So there would be one for Cerner, one for Epic, since those are the big major ones. And instead of just having physician champions, now you have IT champions who can say, oh, this is an easy turn on, or this is an easy way of implementing it. Because a lot of times what happens is, at least in healthcare, the healthcare professionals I've worked with, oh, that's going to cost us too much in our IT department, we don't have the staff to do it. Where if you've got an IT expert and they can read a very simple protocol, they can tell you right there if this is something easy. And it's just another approach to a different set of group or a different set of experts for detection.
Good idea.
Hi, my name's Jennifer. I work for Florida Hospital for Children. I'm the infection preventionist here.
Great.
And I just wanted to add, because I spoke with Susan Jackson, she couldn't be here, but she wanted me to just bring up a couple of little things
Great.
that she thought would be helpful. But first, I wanted to say that I was thinking about the emergency room physicians too, if there's an association, because, you know, generally all of the, you know, cases come in through the emergency room, so they're the first, you know, point of awareness. And so Susan wanted me to mention that the protocol that we have developed at Florida Hospital for Children is available for any hospital that is interested in looking at it and using it as like kind of a first guide and then tweaking it to fit for their organization, whether, you know, they use Cerner or whatever, but they can tweak it to what would work for them as well. And we've run into a couple of little issues along the way. Every case, it seems like we learned something a little more that we can fix. And one of it is we had a child that was coming over to Florida Hospital for Children to rule out. And there was an issue with the CSF being released from the campus that the child was originally at and transferred with the child to the campus in Orlando. So that could definitely restrict the timing of that CSF getting over to Atlanta. And then the other thing was,
I'm sorry, before you go to the next one.
Sure.
What was the issue, do you know? She mentioned.
I think it had to do with their lab at the hospital and releasing CSF.
They didn't want to.
Right. So we just have to make sure that, you know, that education is out there so that if they are potentially thinking that this could be an Amoeba case, that they should, you know, allow that to go with the patient.
Did that get resolved?
I'd have to ask Susan about that. I know that we were working on it afterwards, but I'd have to ask Susan a little, you know, I don't know that answer right away.
For a non-clinician, is there a reason that the hospital wouldn't want to release the CSF?
I don't know if it's within their own policy or what, but.
Is that, would you think that's usual or unusual?
I'd say unusual.
Unusual?
Usually they'd be willing to.
Especially if it was with our hospitals?
Pardon me?
It was with our system, right? Was it like Altamont to South, or was it
You know,
outside? of
I don't know what hospital it was, so I don't have to, I'd have to.
If it was out of the system, maybe
Yeah, they would.
there's a challenge.
Sure.
But what's sometimes more of a challenge is
Yeah,
after the
that's-
patient's already been transferred and the spinal fluid was not sent with the
Oh,
patient,
then maybe.
then the referring hospital may not want to pay for the courier to have it sent over. And that has actually been a reason for delay. They don't want to pay for it. But if it's set up at the time of patient transfer, they don't usually mind letting it go with the patient.
Okay, so maybe that's something that needs to be,
Yeah.
the process needs to be changed or tweaked a little bit to,
Yeah, that
so
when.
that there's no additional.
When the
charge.
referring hospital calls the referral center to make the transfer, that discussion between the hospitalist or intensive care doctor and the referring hospital should include, can you please send us the CSF that you collected? So maybe that should be
Well, I was
built in
gonna say,
the
can you
protocol.
imagine if you
so-
lost a life because of that? I mean, that
Yeah.
would just be horrific, right?
Yeah,
Okay,
yeah, it's frustrating for us.
I'm sure. I can't even imagine, right?
As we're talking about the CSF samples, I wonder also, is there a difference in the samples that, you know, are severely, severe cases of meningitis, thousands of white blood cells, low blood sugar versus, like Sebastian, which had very few white blood cells. Did the Amoeba get destroyed with a huge amount of white blood cell? Can we even check a sample if it takes 2 hours for it to be sent? Because I seem to remember on wet preps or that it had to be a fresh
Yes.
sample.
Yeah,
from
ideally
medical
within 30 minutes of collection. So the delay in the transfer will affect the wet prep. The amoeba may not be moving anymore. There might still be an ability to detect it by the right Ginza stains, since those don't have to be living. But I think if there are a ton of cells in there, it might still be hard to find them. Fortunately, it should not affect the PCR, but that just takes longer. And you were going to bring up another point.
There was just one more thing, you know, she thought it was important for us to mention these little idiosyncrasies that happened along the way.
Yeah, right,
And,
that's what we.
you know.
Could be a clue to.
Right, one problem that we found was that we had one case that had to be shipped out to the CDC, and, but it was on a holiday and it was off hours, and so therefore the courier, it was really difficult to figure out how to get the sample up there. So those are just little things to think about, like on those off hours, on weekends and nights, you know, to have that written in your policy so that you have that ability to not worry about that.
Right, yeah. That's not in the policy, correct? Yeah, good idea.
Seems to happen on a holiday as well, right?
Yes.
I mean, I don't even know who they would call for the overnight. Do they call FedEx?
I think
And that can be
I don't know if they
hospital
hired a private-
specific.
It could be, but it's also a courier, you know, it could be also where we are in the country, it could be a courier
Yeah.
limitation too, right?
Yeah, so that would be something that our policy can recommend be created on a hospital by hospital basis for whatever mechanism they think is.
Yeah, sure you have it off our holiday.
Exactly.
Something to decide, to say, oh, that's a good idea.
Right,
Is it-
weekdays, weeknights,
Yeah,
weekends.
how are you gonna-
What do you do?
Yeah.
So Dr. Dumois, I have a question around the frequency of health education within a hospital system. You know, reaching out to these different groups to make physicians aware of the issue. But just as we heard from Sheila Black today, making the laboratorians aware, your nursing staff, and then the rate of turnover in a hospital setting. So if you just teach once a year, that may not be adequate in order to keep these protocols up front. So what is the current training schedule for personnel in a hospital setting, and how frequently would be reasonable?
Right,
to-
good question. I heard a statistic the other day that keeping knowledge up to date of that nature would be repeated every 6 months in some way. It would have to be a formal grand rounds lecture presentation, but something, whether it's a little thing on the hospital computer screensavers. That's a good idea. Dr. Gaunt and Dr. Valente, are there any kinds of reminder things like that that happen for non-doctors who aren't ordering the implants? You ever see?
I know they have basically huddles every shift, and they do have topics they discuss. And that's something maybe that they should implement they have a rotating schedule of what education should actually be something maybe put onto that docket where, okay, it's May, maybe timing is too, May because maybe the beginning of the season. And that did happen this year when May, and I remember seeing that, we got emails, hey, it's May again, guys, not that, not all year long, but consider this diagnosis when you guys are seeing patients. Did it happen to the nursing staff? I'm not sure. That happened with us. That's something that they do huddle. That's something that maybe have to incorporate that into their list and their protocols. Have nursing.
That's a great idea.
There's bullet points that nursing huddles or nursing education every single month.
Our nursing units do the same thing. Yeah.
So I put that on our agenda.
Yeah. And at least in the spring, that would be the best time.
And then, right.
Yeah. I'm involved with clinical education of mostly doctors at our institution and our affiliated institutions. That's kind of a limited audience, doctors that attend grand rounds or attend some of these other weekend conferences we have. We can offer to add articles to the Florida chapter, the American Academy of Pediatrics newsletter. They put out, I think, a monthly newsletter. Again, just to get the word out, that sort of education to the pediatricians and state. Similarly, the Florida College of Emergency Physicians, if we were talking about, we could ask them about a newsletter. But that's a great idea.
Department meetings in the hospital, or, large community hospital in Lakeland, but there's quarterly pediatric department meetings and
With
then
a lecture.
monthly emergency room, pediatric emergency room physician meetings. So
Yeah.
that type of venue would be good.
So inviting speakers for that. Yeah, those are good ideas. Anybody have any other suggestions that we haven't discussed that you might want to bring up about disseminating this plan? Ideally, we would have a goal of next year having already implemented this protocol in more than just Lakeland Regional and the Florida hospitals.
A question, it's not another suggestion, but
Okay.
I know you guys are readily prepared to share your protocols and algorithms, but who would be the lead personnel to say, if you were talking to people or a large group and say, if you want to implement this protocol, you need to see this person or follow up with this person? Because I have no problem taking the information and disseminating it, but there should be somebody to follow up with
If
on
they
that.
have questions, you mean?
If they have questions on it, or, I think with the, I know Florida Hospital's ready to share their protocols. But I'm sure, Dr. Sarah Kirby doesn't want to get all the questions that come out of it.
Too bad, she's getting it.
Oh.
There
There you go.
You're not here to guess what you get.
Right, yeah, she's not here.
I'll text her right now.
Yeah.
This guy.
Do we
What?
Do we just say the Smelski
Congratulations.
Foundation, or?
That's a,
That would be a good
So that's a
start.
good
Question, so-
question. That's a good question.
so, the
So
question
are-
is, should we create an expert bureau that can be tapped to answer these kind of questions? I don't know that we should post a list of people, because then the first person on the list is always going to be the one to get all the calls.
Steve may have a
but if-
technology where you could let people volunteer to join that, and it's like a bulletin board that
A
would be more
listserv.
private kind of thing, where you could have a bunch of participants of all of you that wanted to participate, and then somebody would post the question.
see.
Or if there's a concern, or they want to talk to somebody who could help, and then people, and it would be private to the people that are invited to it. So you could have everybody who, and have somebody who wants to participate, or the different organizations. So maybe we could talk to him, unless you guys have another way to do it, but that might be.
So funnel those types of questions through the Smelski Foundation.
Well, and it's just,
or
I'm
their
not even
website.
just saying that, but just like through a portal that he would be able to probably offer that possibly would do that. We should talk to him. I can take it, we'll take it back to him as from the committee.
And then we'll need the volunteers who are willing
Yeah,
to
then
answer questions.
we need the experts, right?
Right.
You know,
Well, it's not only that. I mean, I just attended a meeting earlier, and why I recommended the IT is because one of the things we were proposing is, what are some of the issues in healthcare that need innovative solutions? And why I recommended the protocols for Cerner and Epic, or whatever system's being used, it's easy for us in Innovative Network to say, hey, by the way, I came across this protocol, or the IT companies that are out there, and say, hey, use this as a training device on how to turn on an alert. So now not only are you alerting physicians, but you're also alerting parents as well, to this Amoeba. So now it becomes part of your awareness network. But I heard a lot in there about what Florida Hospital's doing, and I kept asking, well, where's Orlando Health in this? I see no mores on here. And I have a colleague that is in care coordination at Orlando Health, so I thought, oh, I'll send her the protocol, but who would she follow up with that, that kind of question. Those are the things that were prompting my questions.
You had another idea before I suggested that one. Did you have another suggestion after one? How do you maybe suggest to do that differently?
Well, I think that whatever mechanism we use to try to disseminate the offer to all the Florida hospitals to start using the protocol, that offer, whether it's an email or some other mode of communication, would include the ability to contact this person or people or this listserv with implementation questions. I think that would be the practical place to put that. I think that's all I was going to say. Didn't you going to say something?
No, that was my idea, listserv, like there's a,
Yeah.
National American Academy of Pediatric listservs for hospitalists, and somebody asks a question, and there'll be 100 experts all over the country
Yeah.
who could give an answer.
We used to have a little listserv in our, a group email that we offered to referring doctors that if they had an infectious disease question, they would send it to this email, which automatically went to all 4 ID doctors, and the first one who had an opportunity to answer it responded. So it might be something like that.
Okay, so I'll put examples.
Is there any information like through the CDC now that we have this department there that focuses strictly on like these amoebas, that they have information that,
They
you know,
do.
can
They have a
be
website
referral
just
as well?
on PAM,
Right.
and that website includes the diagnosis and treatment protocols, well, especially treatment, but also how to send specimens to that lab. It's available if people look for it.
It's almost like that should be in the protocol as well, like, you know, for like a referral type thing.
It is in the list of references at the end. Yes, that webpage is.
So Dr. Dumois, I didn't hear all of Dr. Kirby's presentation because I was pulled away, but she seemed like she was speaking at the end about a rapid test at bedside. I mean, is there anything in the works that you're aware of?
No, she was answering a question from Dr. Cope,
Okay.
and Dr. Cope was asking Dr. Kirby whether she thought that the availability of a point-of-care test at bedside would be of any advantage. And she basically said, yeah, faster information is better. The question would be, how accurate would that test be? That test doesn't exist currently, but if it were to be developed, would it be sensitive enough and specific enough to guide management decisions? I think there's been some discussion over the last year about whether or how to get funding to begin the research on developing such a test. And that might be part of a reason for the question.
The PCR panel, we talked about this last year with the meningitis PCR panels have 30 things that they test for.
Yeah.
How hard would it be to add one more? But we talked about that, they might be on a 5-7 year plan of using just that model and not all.
Yeah, so what Dr. Goff is referring to, that there's a company named BioFire that has created a multiplex PCR for spinal fluid. And with just a little bit of spinal fluid, less than a cc, they can run a PCR that takes 1 hour and 10 minutes and quickly screen for the presence of the DNA of several viruses, bacteria, and 1 fungus. But Naegleria is not on the list. So I called BioFire and asked them, well, could you just add it? That was before I knew about what the technology was for this PCR. It is really sophisticated stuff. So they said that this was a brand new test that had just come out, and our hospital just started using it 2 months ago. And they usually do not review whether to make modifications to the contents of the panel for at least 2 to 3 years. So with it being a new test, they're not even going to look at adding or removing anything from it for 2 to 3 years. They actually told me, well, and it's not even common enough a condition for consideration, and I suggested, well, it may be more common than they think. And then I also mentioned the importance of early diagnosis, more so than for some of the other conditions. So The rep said he was going to take it back to them, but I think it may have just died there. Some hospitals can try to develop their own PCR for Naegleria, and they could even copy the PCR protocols that are used at the CDC. The problem is that when a hospital decides to create a non-FDA approved PCR test, they have to validate its accuracy first. And the way they do that is testing it against positive patient specimens. But I did find out at lunch that if a hospital was interested in trying to do that, the CDC would provide positive samples of Naegleria that they grow in culture. It's just a lot of work and it takes months of work. And hospitals will usually prioritize putting work into a new PCR for something that's coming. So that, unfortunately, it would seem like such an easy solution to get back at it. And it's something that I think we can keep at BioFire. I mean, keep hammering them with that question. And if they start hearing it more than just from me, maybe that would be something we could disseminate to laboratory people, laboratorians around the state. Start asking BioFire reps for this PCR.
Multiple people are asking for it.
Yeah.
Volume.
Yeah. It's easy to ignore Dr. Dumois, but if it's 50 different hospitals around the state, that might be hard for them to ignore.
Does
Good idea.
BioFire have a competitor?
There's an angle.
Not for
Not yet.
hospitals, no.
No?
There are other companies that make multiplex PCRs, and the big one that I know of actually markets to outpatient clinics. They don't sell the machines to do the test in a hospital. They do it at their centralized lab. They actually sound very flexible.
Are there centralized labs located in Texas and Florida? It would bring it closer, is what I'm trying to
Yeah,
say.
I don't know where they're located. And they offer quick turnaround times, but I don't think it would be any faster than the CDC. Well, these are great comments. I'm going to tabulate them, and anyone who's interested in knowing what the further progress is on this, we will maintain a group email, so that I can give you all updates on how we're progressing with this, and seek your help if we need it. But hopefully in the next week or so I can send out some brief minutes of what we talked about. But I think it's almost time for us to head over to the auditorium. Thank you.
Thank you.